Well, what we call the intrinsic subtypes of breast cancer, which are basically the subtypes, regardless of behavior, right? Just are they biologically different? Those have been, kind of recapitulated in multiple different methods. They're clearly there. There's who knows how many, 5, 6, that's the current tally. And those are the traditional luminal A, luminal B, basal-like, HER2 enriched, and more recently the Claudin low. Those inform our understanding of biology. The next step of how they inform our understanding of treatment is still a work in progress. Separate, because those were developed not for a particular application. They were just developed to understand breast cancer. Now, in truth, they are prognostic. So there's a version of an intrinsic subtyping that's, I think, already been approved in Europe and is at the FDA, called the ROR score, that just basically intrinsically subtypes tumors, and that's prognostic in ER-positive, HER2-negative breast cancer, that was shown by Mitch Dowsett last year at San Antonio. But there are also assays that were explicitly developed to prognosticate. The 70-gene MammaPrint, the Oncotype DX recurrence score. I mean, those are effective prognosticators. Again, most, in ER-positive, HER2-negative, we don't have anything that works in ER-negative or HER2-positive disease at this point that's valid. And then there are these other ones I mentioned, the BCI, the EndoPredict. I mean, there are a number of these. There's a Amsterdam 76-gene assay that's been around for many years. So I think the question that faces us, and that we're just starting to do, thanks to, the Trans-ATAC has done some of these things, is to say, okay, let's take all of these different approaches, figure out which ones are relatively better than others, or which ones inform each other. Now, be afraid, right? I mean, what you kind of don't want to find out is that you need to first do an intrinsic subtype and then you need to use another assay within the intrinsic subtype to identify it, to prognosticate. But I think some coherence in terms of putting together these pathways within a subtype makes sense to me, because, again, I don't think you want to be looking broadly at breast cancer. So I think we already are subsetting our tumors by clinical assays, because at this point we don't have a more sophisticated way to do it. But I think in the future we'll probably be much more molecularly characterizing the tumors and then looking at some of these assays to give us better information about treatment.